Everyone, welcome and thanks for joining today's webinar, which is the 13th session of our 2021-2022 project, and that is HIV Awareness, Prevention and Education Project in Pakistan, and designed and led by APPNA-MERIT HIV Committee. This project aims to reduce HIV stigma, increase HIV awareness, and increase knowledge about HIV disease among the healthcare communities in the Pakistan using educational and research tools. I don't know my video was. Please note that this committee is not affiliated with any political party in Pakistan. This project is a volunteer academic activity, and all views presented in these webinars are presenters' own views, and they do not necessarily reflect any institutions. And we dedicate this session to World Hepatitis Day. Our moderators today are Dr. Saima Abbas and Dr. Hamad Ali. Dr. Saima Abbas is an infectious diseases physician, and she's working in USA, and she's co-chair of the APPNA-MERIT Committee. And Dr. Hamad Ali is a medical epidemiologist. He also works in USA, and he is our second co-chair of HIV Committee. So I present Dr. Saima Abbas and Hamad Ali. Thank you for joining today.
Thank you, Fiza. Let me share my screen. Okay, so Assalamu alaikum everyone. Bismillahir Rahmanir Rahim. On behalf of APPNA-MERIT HIV Committee, I welcome you all to our first webinar of 2022. And the topic is in keeping with the World Hepatitis Day. And this is pertaining to HIV, which has been our primary focus. So this is iatrogenic transmission of HIV through unsafe reuse of needles and syringes in Pakistan, a public health crisis, which, as we all know, has gained a lot of global attention. So there is no power for change greater than a community discovering what it cares about. So after the pandemic response with COVID-19, which we truly cared about, I feel that if we start caring about HIV, there is a lot of power in that, and hopefully some change will also follow. So one recognition, Hina Javed, who's a family practice physician, has been a very active part of our APPNA-MERIT HIV Committee. And this is an article which came in the news yesterday, a guest editorial, Burden of the Disease to Address the Hepatitis Challenge in Pakistan. This is an excellent read if you want to update on the hepatitis situation in Pakistan. So hats off to Hina on that. So what are the objectives for this webinar? So recognizing that there has been a shift in mode of transmission from sex to syringe. Now this phrase, sex to syringe, was borrowed from Dr. Shehzad Ali Khan's comment in one of our webinars last year, because the perception is that HIV is a sexually transmitted disease, and most healthcare providers are not aware of and also don't take responsibility for their role in the mode of transmission shifting to the syringe. Also, the key population that is most which is, gets the most attention is the people who inject drugs. So the syringe here is not only confined to those people, but also to the iatrogenic transmission that happens in quack clinics by physicians and non-physician staff, dentists, and barbers and other piercing places or tattoo places, which are some of the areas to focus on. The second important misconceptions regarding unsafe injection equipment reuse. So I think some of the outbreaks that were investigated, they found that the people who were doing these unsafe practices had these misconceptions and false belief that they were actually safe in what they were doing. And that's an important knowledge gap to address. The third thing is, which after talking to people in the ART centers and Dr. Umair, one of the struggles that they have is taking a full-blown AIDS patient, putting them in the hospital and asking physicians, surgeons to take care of them. There is so much stigma in the healthcare providers. And one quick reminder is that the infection control is not different from Hep C. You wear the same PPE, the sterilization of the equipment, everything is the same. And because Hep C is much less stigmatized, we just need to educate our fellow colleagues, physicians and surgeons about and remind them about this. The fourth point, which I hope we can, all our panelists can comment on this, is how do we overcome the disconnect between the three major stakeholders? Every conversation, every webinar, every strategy ends with this disconnect. And this point, Bushra Jamil had rightly mentioned in the first webinar, that the policymakers, the funding agencies, and what the healthcare providers are seeing on the front lines, there is an absolute disconnect in all these three major stakeholders. So if all the panelists can address this, that would be great. And the last point is that how do we evaluate and address the health system's governance and leadership gap in Pakistan? Now, with the COVID response, I know that it can be done, but how do we evaluate this pertaining to HIV is some of the objectives that I hope we can answer during this talk. So there is no doubt in anybody's mind that iatrogenic transmission was responsible for 5 out of 7 outbreaks in Pakistan. And the one thing which Dr. Bushra Jamil had aptly mentioned was that the outbreak is misleading, because when you look, you find, you react, you call it a hotspot, but really this is an insidious culture that we have of overuse of injections, and it might be happening right under your nose, and all you have to do is look. So the World Health Organization has warned Pakistan that they have the highest rate of increase among all countries in the region, and these are the pre-COVID warnings. Pakistan has the highest intake of syringes per person per year in the world, 8.2 to 8.5 injections per person annually. And unfortunately, 94% of these injections are completely unnecessary. So the bottom line is that people who inject drugs and iatrogenic transmission are now the leading cause of HIV spread in Pakistan. I found this study very interesting. This is from Cameroon, which they did an investigation of an outbreak, and they found these misconceptions. So the first misconception that people, first of all, what is direct reuse? So you take a needle and you inject 5 people with the same needle. That is direct reuse. But these indirect reuses may be a little bit more subtle that need to be noticed and educated upon. So the first is, it is safe to reuse a syringe after changing the needle. You will be surprised how many people have this misconception. The second is, it is safe to reuse a needle or syringe on the same patient, re-entering a multi-dose vial or saline bag with a used needle or syringe. This also comes under indirect use, reuse. And then the last one is, it is safe to reuse a needle or syringe when accessing an IV port separated from the patient by intervening lengths of IV tubing. Bottom line, all three have been linked to HPV, HCV, and HIV transmission. So wherever you are working, if you catch staff doing these, you have to educate and remove the misconceptions. And this could be physicians. We just have to be aware of this issue. This is one topic which breaks my heart, and I thought it is very important to bring it up, which is HIV stigma among healthcare providers holding back prevention goals. And this is an article about the United States, where we think the stigma is much less. But this was one of the things which I thought I could relate to Pakistan. So this is a legitimate, genuine issue which people in Pakistan have acknowledged. there is provider fear of acquiring HIV through occupational exposure, leading to reduced quality of care, most of the times refusal of care, and anxiety when providing services to people with HIV. And this fear was higher among providers with limited awareness of or access to post-exposure prophylaxis within their healthcare setting or clinic. So this is the US. But in Pakistan, in our context, poor infection control practices and poorly functioning, and I don't know how many existing employee health programs are there in hospitals that address the needle stick injuries. But this is one thing which really needs to be addressed if we want physicians and the stigma in them to decrease. So the World Health Organization has guidelines on what are the safe syringes to use. And these are the 4 unsafe practices that are prevalent in Pakistan. So the first is, I'm just going to read the titles: the reuse of injection equipment, accidental needle stick injuries in healthcare workers, overuse of injections for health conditions where oral formulations are available as recommended as the first-line treatment, and unsafe shops waste management, which is a huge issue in Pakistan. So this brings us to our esteemed panelists. I'm going to stop sharing my screen here, and I welcome our first speaker, Dr. Arshad Altaf, who is the WHO representative today. Let me find his biodata. Okay, so we are very happy to have Dr. Arshad Altaf in the conversation today. He's the Technical Officer and Research Promotion and Development World Health Organization, Eastern Mediterranean Regional Office in Cairo and Egypt. He provides technical support to 22 countries in the region, including Pakistan, on strengthening research capacity and conducting research on public health priorities. He has worked in HIV and AIDS and injection safety advocate and researcher for 2 decades. Very importantly, he has led the development of Pakistan National AIDS Strategy twice for the Ministry of Health. And after 2019 Rato-Dairo HIV outbreak, he was invited by the Minister of Health to develop the Pakistan National Action Plan on Injection Safety. He has close to 50 publications in peer-reviewed journals. He also reviews HIV and AIDS-related manuscripts for several esteemed journals. So Dr. Altaf, please highlight your experience, your wisdom, and how you can help us. Thank you.
Thank you very much to Saima and all the organizers for providing this opportunity to speak to you guys. I don't think what I'm going to say will be new. You are such an august gathering and well aware of the issues relevant to HIV and injection safety in Pakistan. So please consider what I say as a refresher. Most of the information you guys are well aware of it, and I will just walk through it and maybe we can generate some discussion. I do want to understand just one thing, that what is the ultimate objective? Are we sensitizing the participants, or in the long haul, you guys also want to do something in Pakistan in terms of intervention, working with the government, with an NGO, CBO? This is my only question, and then this will help me in speaking further. If any one of you could kindly answer that. Saima or Hamad, whoever.
Okay, so I think the objective of all these webinars has been to increase the HIV awareness. So the people who are attending these webinars, they are pretty sensitized to all these issues. Our frustration is implementation of strategies and what is standing in the way. So this is for all physicians who are well aware of frontline frustrations.
Sure. Okay, thank you so much.
Yeah, I will also add here that we have been creating the partnerships with Pakistani institutions since last 2-3 years. And our best effort will be for them to lead And being the researcher here in USA, we will try to provide more opportunities for research grants and create more, platforms like this.
Excellent, excellent. Dr. Najam has to say something, I think.
I'm going to try to keep quiet, and I apologize for saying something. It's just that I feel that if you complain about brain drain in Pakistan, I feel super guilty, because not that I call myself a brain, but I think that I drained Pakistan. I do have my passion in this project. Arshad, I met the first day that I started working as a healthcare worker in Pakistan. The first day, I was told to go and report to a clinic where there was a doc doing some blood work, and I was supposed to take over the clinic. It was a truck driver one, I was near the docks, and I arrived there, and then there's this guy giving injections, and I tried to draw blood, and he started criticizing the way I was doing it. He was doing it wrong too, but he criticized and corrected me. So, and that's been a lifelong relationship that held off. My thing is that in Pakistan, I did a couple of key things 20 years ago. Arshad and I realized that the hepatitis C epidemic we were seeing was the tip of the iceberg. And I mean, it wasn't us, it was shoulders of giants. There were other epidemiologists working there, both from the United States, Steve Luby specifically, and a couple of others. I think Amir Khan was the other guy. That we realized that Hep C was the tip of the iceberg, that there would be HIV soon. We actually investigated, Arshad and I. We did blood work in hundreds of commercial sex workers, sailors. Their veins were very prominent, as well as the truck drivers. And we did tons of blood work, and we didn't find too much HIV at that time. A couple of cases, I believe. But Hep C was pretty prevalent. And when we tried to investigate, or Dr. Javed Khan did that at that time, I've never met him, but what had happened is that they found clusters of these cases around clinics. So we knew, and we published around that time. But think about this. We've been publishing this for 20 years. We've been predicting this for 20 years, and we were not able to stop the iatrogenic transmission now. So what did we do wrong, and where we went wrong? And I believe that this is going to require out-of-the-box thinking. It's going to involve not one modality of treatment, but multiple. And I already had research around the topic and how to bring about change 20 years ago. It's my fault that this research wasn't popularized. So Arshad, around the same time I was doing that clinic, I was also, a year later, I was the principal investigator in the BASICS project. And that offered a solution, a glimpse of the solution. They were able to curb significant childhood mortality just by maternal and children observing doctors treat their patients. And then finally, Dr. Saima, I'd like to say to you that we should not use the word quacks, in the sense that these are providers. We saw it was the doctors, the MDs and the MBBSs that were just as involved and fought more and spread. And I also tell you, they were innocent in the sense that they were trying to immunize kids. So it was nobody's fault. But if we go to the traditional birthing providers, go to these people that go into people's houses, even the actual people who claim to have knowledge about stuff, Hakims and other people, they're not quacks. They're trying to help, or they're trying to make a living. They are not trying to harm their patients. And sometimes if you get to them, you can improve vaccination rates in the area. You could decrease use of syringes and paraphernalia. And we were able to affect that 20 years ago. So my project was just to observe moms and physicians taking care of oral rehydration. When anybody, any kind of provider, doesn't matter what letters they have in front of their name or what they claim to be, if they saw a sick enough child that was beyond their care, dry tongue, listlessness, they were able to refer to a tertiary hospital. And we save lives just by that, just by the mom or the child observing their kid brother being looked at. And the observation itself turned the physicians towards doing the right thing. If they were not doing it already, they were already doing it. So we incorporated needle reuse in there. When you go to a doctor's office, do they open a syringe? Do they ask you to buy one? Where do you buy it? Is there a reputable way of buying it? And that by itself reduced needle reuse. There in that project, almost 100%. So it doesn't take much. Finally, so that's one tool, one way of doing it. the other thing is you pointed out a really nice publication, and I bet when I read it, I'm going to be inspired. And there's going to be 20 other like it. In fact, I was inspired by my own or Arshad's over the years. What has led to these papers being in publications that are English or I believe it's social media and everything else, where if we can get the message of the paper in one line in a tweet or on Insta or with pictures to the children and the people who use phones in that community, I believe that the findings of these papers will be popular with the people who are using the clinics. Forget the doc, we educate the doc, obviously, but if we educate the people that are going into the clinic and they buy their own syringes or have a supply of them, I believe that this will be brought to a stop very fast. So the information dissemination is where we lag at. And I think that we didn't have the tools to do it.
Sorry for interrupting, but extremely valid and awesome points. We will definitely come back to these. But just in interest of time, we are at 11:22, so just want to be mindful of the panelist time. So handing it back over to Dr. Altaf, and we'll definitely come back to the awesome points that Dr. Zaidi raised as part of our discussion.
Thank you. So I'll try to share my screen, and I hope it works. Please let me know if you can see the slides.
We can.
Okay, Najam, thank you for pointing out such awesome points. And I totally agree with you on the importance of the tools that we have nowadays that were not available decades ago, actually, when you refer to the social media tools and the power of those tools and the impact that they can make. There is no doubt in that. Anyway, let me quickly walk through these slides and then we can have more discussion. So I'm going to talk about a little bit about HIV and a little bit about injection safety in Pakistan. As I said earlier, that you guys are well aware of the situation. So consider this as a refresher, please. So the overview that I'm going to cover is the HIV response and the continuing problem of injection safety in Pakistan. This is the gloomy picture of the HIV response in Pakistan. We have 250,000 HIV positive people, as you can see in the blue bar here.
Dr.
And,
we can only see the first slide.
Really?
Yeah, it hasn't moved for us.
So maybe then you guys need to move the slide. I have emailed it to somebody. So let me try it one more time. And otherwise
Now we can see the slide number 3.
So this is not the slide projection mode, but is this visible to everybody?
It is.
Yes.
Let me try to increase the size. Is this working okay?
Can you hit the slideshow and that would be smoother?
Well, I hit the slideshow and then it wasn't moving forward. Let's try again. Visible or not? Please tell me.
Yeah, it's visible, but it's not coming as a slideshow. That's okay. Go ahead. We can see the slide now.
No, then let me increase the size here and maybe because people have to see. Some people may be joining from their phones and tablets and etc.
Yeah.
So okay, I'll continue. And if you want me to stop for a couple of minutes and somebody can take over and project my slide, I'm okay with that. However,
there's another way of doing it. If each of the audience makes it as maximum in the view mode, that could also increase the size.
Yeah, true. So I'll continue, okay? And please let me know if you want to change the way I'm projecting. So not in the slide projection mode right now in PowerPoint. And as I was saying that this is the estimated number. The blue bar is showing the estimated number of PL-HIV Pakistan, people living with HIV. And a small percentage of them, less than 50,000, are aware of their HIV status. Even less than that are receiving medicines for HIV, which are called ARTs. And the final two bars are talking about the suppression of viral load, which is the ultimate goal when you initiate treatment. And there are scores of publications available, research, programmatic data showing how important it is to initiate medicines as soon as somebody is diagnosed with HIV. Unfortunately, this is not the case in Pakistan, and there are a number of reasons behind it. Many of you are aware of it. We'll try to touch some of those. Okay, so I have to go it this way. So if let me try the slide mode.
Dr. Rashid, we can share the slides.
Oh, you can? Okay, so let me
screen.
stop sharing and I'll stop sharing and you
Yes.
please share, okay?
Okay.
Please go ahead. Can you go in number 4, please? No, bahut aala. Thank you so much. So again, a refresher for you, the chronology, as I understand that Dr. Bushra Jamil has spoken to you guys about it in an earlier webinar. So consider this as a refresher. So these are some of the reported HIV outbreak in Pakistan, starting from the first one in 2003 and 4 in Lalkana among people who inject drugs. At that time, only 10% were HIV positive. However, that is when HIV started to gain some attention in Pakistan and among PWIDs. Prior to that, most of the transmission was also through sexual route. However, the situation changed after this outbreak, and following this, there were surveillance rounds which showed that HIV has reached more than 5% among the people who inject drugs. So the second reported outbreak after 5 years was in Jalalpur Jatta in southern part of Punjab among a low-risk community, and subsequent investigation by CDC and colleagues from the field epidemiology training program in Pakistan found out that unsafe injections by healthcare providers were one of the key reasons for transmission of HIV among this community. Then another 8 years passed, and there was another outbreak, but this time in a different group of, let's say, low-risk group, I would say, but they are high risk because there are patients who are on dialysis. In terms of the risk factors, it was found that the 2 reasons were identified by National AIDS Control Program at that time: poor infection prevention and control practices, and many of the patients had received blood transfusion as it's necessary among patients who are on dialysis. So, and obviously there was one unit and untrained healthcare practitioner who was using or managing the dialysis machine at that time. It led to transmitting HIV among 19 patients with chronic renal failure. There were outbreaks reported in 2018 in Port Imrana near Sagoda. Again, the investigation found out that it was by unsafe injection practices by both trained and untrained healthcare providers, and the population that received were obviously patients. Next slide, please. Then, well, you guys are well aware that the most famous one, which brought attention to Pakistan once again in 2019, this unfortunate incident in Rathod Dero Lalkana, where a huge number of children and some mothers were HIV positive, and investigation by the international team of WHO and other stakeholders found that it was unsafe injections and poor infection prevention and control practices which led to this outbreak among children and mothers. So since then, many cases are reported, especially from communities in Sindh and Punjab, in rural communities, and it's not stopped. Some of them are reported in the media, nothing happens. Some of them are reported in the form of letters here and there, but this is a continuing process now, and it's an unfortunate situation that HIV is continuously spreading through unsafe injections, blood transfusion, and other modes as well, I'm sure. Next slide, please. So just to contextualize for you that then HIV among the key population, which are sex workers, men who have sex with men, and PW, people who inject drugs, and transgenders. These have been the key population under the limelight for a number of years. I want you to focus on the lowest number, the gray bar on this slide. And what I'm trying to tell you here is the situation of the program. The programmatic coverage is so low that it is not leading to a behavior change in terms of improved or reuse of syringes by PWIDs or safe sexual practices by the other three key population group. And ultimately, we may talk more about this issue of programmatic coverage, as you are well aware of this as well. Next slide, please. So this is from the surveillance data from 2009 till 16 among female sex workers. If you look at the reported data that condom use in last sexual act by the female sex workers is in the range of 40 to 50%. Yet from 2009 to 2016, HIV is slowly increasing and has reached, this is now almost 6-7 years old data. But HIV, which was previously confined to people who inject drugs in terms of key population, followed by transgenders, is also now creeping up among female sex workers. Next slide, please. So you are well aware that there are 3 or 4 key players responsible for the HIV response in Pakistan: the Ministry of National Health Services Regulation and Coordination, National AIDS Control Program, or a management unit nowadays, which is coordinating the Global Fund supported initiative in Pakistan in terms of AIDS, TB, and malaria. Then there are the provincial AIDS control programs, and then obviously the frontline workers or the organization that do most of the work are NGOs and CBOs. Some of them belong from this key population group, and they are responsible for doing different behavior change implementations from their program. Next slide, please. These are some of the findings from the programmatic review, which was done in 2019 or 20. And if you look at on the left of your screen, so I don't know how many of you are aware that there was a constitutional change in Pakistan, and following that, all responsibilities or everything changed. Health became a provincial matter, and provincial programs have more responsibility when compared to the National AIDS Control Program. So the findings showed that that change has not worked in terms of what was required for HIV in terms of the integrated approach to HIV response. And obviously another finding was that the HIV programs, they lack the political leadership to bring change. Next slide, please. Other issues from the programmatic review of the HIV response in Pakistan, there are issues in terms of funding. And when the money was available, there were issues to spend it. It's a slightly complex matter, may not be easily understandable to people in North America. And although now there are a number of ART centers, more than 50 as I understand, but still the number of people on ARTs remains quite low, unfortunately. Next slide, please. So shifting gear towards injection safety, Dr. Saima has talked about it. You guys are well aware of it. So I'm just sharing a paper that was published a few years back, and 2019. So it was the review of the demographic health service data, and what they looked was to compare the situation of injection safety and frequency from the different WHO regions, and the data were available from 40 countries. So what the review found was that injection frequency decreased from almost 4 per person per year to 2 per person per year. And reuse also came down, and the use of new injection devices increased significantly. The annual number of unsafe injection also reduced. However, again, unfortunately, the unsafe injection practices, the review found did not improve, especially during the 2006 and 12 period for Pakistan. And in spite of the limitation of data, this provided a measure of progress in terms of injection safety over time. Next slide, please. So this is recent. There was a seroprevalence survey done on hepatitis B, C in Sindh province, and just sharing some of the key findings in terms of hepatitis C. In Sindh, it was found, if you look at one of the table on the top table, it's almost 6%. Among females and males both. And the identified risk factors were living with somebody suffering from HCV, receiving injections, receiving blood transfusion, and dental treatment, as well as hospitalization. The map on the right side is showing HIV HCV prevalence in terms of the different districts of Sindh province. Next slide, please. So if you really want to improve unsafe injection practices, and we have worked on it, and there is global precedent and literature available, that we have to empower the community to question the provider in terms of the need of an injection and the type of syringe used. And this, as I said, we have tried, and it has worked in more than one instance. And not only in Pakistan, this has been tried in other countries where they empowered the community to question the need of an injection and the type of syringe. That is, please, did you open the syringe in front of me, things like that, and it worked. However, these were intervention projects, and we need a lot of resources and logistics to do it at a wider scale for a country like Pakistan. We need to address the issue of untrained healthcare providers in Pakistan. We need to immediately institute the use of reuse prevention or auto-disable syringes in the therapeutic sector. I worked closely with the manufacturers and the ministry when this outbreak happened, and there were such absurd reasons presented by the local manufacturers, none of which comply with the international standards. But the government has to, put its foot down and overrule and just institute this rule of reuse prevention syringes, initiating the use of these syringes. Some conventional syringes in the clinical practice may be required because some situations require multiple plunger movements, and obviously reuse prevention syringes do not comply with that. So we have to keep that in mind. Next slide, please. In terms of the HIV response, the provincial governments need to step up and spend money, and there is no shortage of money. If you forget what is happening right now, the economic turmoil, in the past, there has been money. The problem has been they have not spent the money in terms of HIV response and initiating projects which could lead to behavior change among these key population. It must be ensured that the services at the ART center are integrated in terms of treatment, counseling, testing, adherence, education, and condoms. So this does not happen. The patient gets a run around in many of the ART centers to get the test for, I don't know, viral load, etc. Even simple as CVC, the patient has to go out. And obviously the stigma and discrimination among key population, it's such a powerful barrier in terms of improving HIV services. It has to be addressed. Next slide, please. There are some positives. For example, reuse of injection equipment has come down. I have seen it. There is literature available. And I believe that although there is not such concrete evidence, but something has worked, and probably the digital platforms and time, people do now ask the providers about the type of syringe used on them. Most of them are educated middle class patients. But this change has come because if you understand, and many of you understand this well, our social structure is such that we do not question the healthcare provider, and whatever the doctor says, we just comply. However, I have seen these changes come about, and which is a positive sign. In terms of the HIV response, the COVID-19 pandemic, although brought lots of challenges, but the HIV response in terms of distribution of medicine, etc., in Pakistan did reasonably well job in providing these services in whatever scale it was. I think this is the last slide. Yes, thank you so much for listening to me. I stop here.
Thank you so much, Dr. Altaf. That was an excellent presentation. Although we will have more questions about your frustrations that you had with all the information you had. But in view of the time, I'm going to move on to our next speaker, Dr. Najam Zaidi. He is a clinical infectious disease consultant at Morton Hospital in Taunton, Massachusetts, and Director of Antimicrobial Stewardship and Chair of Infection Prevention. And he has a keen interest in teaching and has been doing that for more than 20 years. He's currently enrolled in the Brown University's Master of Science in Healthcare Leadership program, where they basically trained to make a real positive impact in the world. He was volunteering at Al Khan University in 1996 as a field epidemiologist. And I think his friendship with Dr. Altaf goes all the way, as he mentioned earlier. He has done projects on studying behaviors and injection drugs in long-distance truckers, sailors, and commercial sex workers. And he was also part of the BASICS project in the study which he mentioned earlier, in which they were studying behaviors in community physicians and traditional non-physician care providers in the urban slums of Karachi, which later evolved to influence a needle reuse disincentive. An exciting aspect of the project was the educational empowerment of the community observers, including mothers of sick children and sometimes the older children themselves, in reducing and eliminating needle reuse. So Dr. Zaidi, you already highlighted a few of these points earlier, but coming back to the needle reuse disincentive, what strategies would you suggest? I mean, definitely empowering the public, the children, the mothers. I mean, that sounds like a great, but any other strategies that you would like to suggest? Thank you so much.
First of all, I apologize about speaking out of turn. I didn't realize that. So I don't have a presentation. I have some experience and none recent in fighting this. And my frustration is low because I've never done what Arshad has done in the field and his leadership there. The key point about one of the things that keeps coming up again and again was, we did not, in the BASICS project, we did not think of anybody as a quack, or at least did not judge them. So when the education was required as to needle reuse, one of the key things was we found out that the traditional, non-traditional providers, they outnumbered the regular people 10 out of 1, and they were making a living. You cannot reduce quackery, but you can educate the quacks, if you want to call them that. They don't like being called that. So, and the education is fairly simple. I mean, your message is don't reuse the syringe. Then their next thing would be, well, my patients ask for syringes. So then we have to basically go to the patients and tell them not to ask, not to expect a syringe. And that is extremely tough. But it is doable, and it is a low budget thing if you already have a presence in the community. So the presence in the community where there's research going on, as you were mentioning in Aga Khan, is easy to do. So you go to things like really go to in Sultanabad or someplace like that in Karachi, where it's all the urban slums, great, you can do it. What about the other communities, and what about where all the other people are living? And that sadly will not come from somebody who's an MD or an MBBS. The person who's practicing there is going to be a daya, i.e., one of those people that help with birth, or a quack. And if you're going to call them that, there's not going to be an education. But I believe that in the communities, the information dissemination can come from the parents, television, social media, and educating the care providers, whatever field of medicine or non-medicine they come from. The second part, and it has to be done. The other thing the key thing that we noted back in the BASICS project, which was quite successful, was like the sustainability of it. If you educated the families, it took several years, maybe 10 even, before there was a relapse. And that's generational if you think about it. So if you educate that generation, there's a sustainable effect in that area. So, and Arshad is nodding his head, and we all sort of know that instinctually. I don't know how to go about doing that in Pakistan anymore. I do know that everybody has a cell phone. They do messages. I believe we did not have this tool a long time ago. And I think this is probably the only way where it would get into people's minds. It might have to be through a popular artist. It might have to be through a popular site or messaging. So you have to do social influencers, and they're the biggest quacks of all. But we have to kind of resort to talking to them. With regards to the government disincentive, I believe that, we've proven here in the United States, no amount of money is going to be able to be influential against political divide. And if there's political divide with two major parties in the US, I don't think there's going to be any kind of political union in Pakistan. So how do you go around doing that? So what you kind of sort of do is try to pass laws that are permanent, and that is not easy to do, but that is probably the only way. Whatever tumultuous government you have, you pass a law about budgeting and getting the money to the people. I don't know whether that's going to be an ultimate solution, but if you have laws regulating industry and incentives to do the right thing, like solar being an incentive in the US, that probably is the the only way. The other influence is going to be when you were Dr. Saima was talking about stakeholders. So in business school, which is what the master's is a part of, stakeholders include the patients and the children who are getting injected. Now, how do these stakeholders get empowered and speak up? That we have to figure out by some out-of-the-box method. But they are the key stakeholder. I know we control the purse strings and the money, but without them, you can't inject. So they are the key stakeholders. So they should be made aware that they're the key stakeholders. So bringing about a culture change in education, requiring people not to require syringes might be tough, but it is doable, and it's probably the cheapest way to go. And that's about, I'm sorry I spoke up before. This is all the message was. And I hope to be able to participate in the future, so I'll keep quiet now. But I think that's probably the only way to get it moving forward. Sorry, you're muted, Simon.
I'm in, yeah.
Okay, thank you so much. Excellent points. Thank you. Go ahead, Hamad.
No, thank you, Dr. Zadi. Really, really excellent points indeed, because the science and the clinical side and all of that is extremely important and all, but as you were saying, unless we do this social community side, there's no way for us to move forward in an effective manner. So just in interest of time, moving on to our next speaker, Dr. Danish Bhatti. Dr. Bhatti is an associate professor at UCF College of Medicine, and he's a neurologist. Dr. Bhatti is the founding director of MERIT Academy, online distance learning resources for continuing education. He is also the founding member of Tajdeed, a group of physician entrepreneurs with focus on healthcare innovation and market disruption, with a special emphasis on those leveraging developing countries for R&D. And he has a strong interest in online and blended learning. So Danish, the two questions that I have for you that we wanted you to touch on is, number one, if you can talk a little bit about who is currently manufacturing injection equipment in Pakistan, and then related to that, the question two is, how can the local industry step up in the country? Any ideas on what the local entrepreneurs can do to compete with this big industry which is producing syringes and disposable systems locally?
Thank you. Thanks for having me. An interesting tidbit, Hamad is actually a classmate of mine from King Edward. And then thank you, Dr. Faiza, for inviting me. I was chair of APPNA-MERIT up until last month and have worked with Dr. Gilani for her excellent work in HIV. I'm really impressed with all the work that's being done. So I'm not an HIV or infectious expert. So my role here is because of my interest in Tajdeed, which is a group of us Pakistani diaspora physicians, mostly APPNA members, who are trying to pool together resources, human capital, monetary capital, to see if there could be innovative startups that can make more efficient healthcare delivery, more cost-effective delivery. So that of course include the telemedicine, but there's also medical device manufacturing is part of that. Coming back to the question at hand about the needle reuse challenge in Pakistan. Looking at the data, online, talking to some of the friends who are part of these networks, seems the numbers. If we talk about big broad numbers, the total injectable use or per year in Pakistan is roughly about 1.4 billion, 1.5 billion. The number varies because depends on how you sample or where you get the data from. So about 1.5 billion plus minus 300 million syringes are being used in Pakistan per year. The current capacity of manufacturing in Pakistan is less than 600 million. One of the biggest manufacturers is Amson. They have a capacity of 350 million, but they're only able to make 250 million of these syringes. And just to tell you how big of a shortage this is, that their capacity is already sold until 2025. So for the next 3 years of the syringes they will be making, they already have orders booked. And who's the buyer of those syringes is UNICEF. UNICEF have bought all of their full capacity, anything they can make for the next 3 years. And UNICEF is this central
That's
purchase
Danish
model.
only for immunization syringes, I think, just to interject here. Therapeutic syringes is separate. Just please go on. Sorry.
So UNICEF basically does this purchase model. So I was interested why UNICEF, and UNICEF has this bulk purchase model where for developing countries, it purchases material cheaper from whatever resources it can, and then it redistributes it among those countries. So the syringes that the UNICEF is buying from Pakistan, they are not guaranteed to be used in Pakistan. UNICEF has the purchase arm of UNICEF will then decide where they will distribute these syringes based on where the need is, where project starts, what happens, what have happened. But they basically buy, so there are central purchase departments. So there's similar model in America. There is central purchasing happens here for hospitals. You correlate and form you get bigger discounts that way. You get bulk discounts. But that quantity is already sold, and everybody else is a small scale manufacturer. Overall, the numbers, if we look at reuse, so the WHO did a study, I think in 2004, and they were saying that anywhere from 50 to 75% of Pakistani, so that is almost 1 in 2 to 1.5 to 2, get one injection a year. So at least one injection, 1 in 2 Pakistani. So half of the population getting at least an injection or more. And then the number for reuse is anywhere from 17% to 50% of these injections. So anywhere from 1/7 to half of these injections that are being given in Pakistan are needle reuse, because as I said, the need is documented need is 1.4, 1.5 billion, less than 600 million of documented capacity, but most of the manufacturers are not producing at capacity. So that the rest is imported. Now, as I think Dr. Altaf was also pointing out, there are two types of syringes. One are the syringes for immunization and insulin use. That's a small scale thing. These syringes have needles that are glued to the syringe. So needle cannot be removed, and it's part of the syringe. But most of the syringes, which are the injectable therapeutic syringes, which is 95% of the utilization, actually have removable syringes. So you can just take the needle off, keep the plastic body and put it on. Let me just share a screen so we talk about the quickly anatomy of the syringe, so everybody's on the same page on what I'm talking about when I mention. So I'm going to share my screen here. So this is a syringe. So you have a plunger which has a gasket on the top. You have a barrel. You have the needle with a cap. So cap is separate, but needle is basically this plastic stub, and then have a needle hub and a needle on the top. Now, all the manufacturing capacity in Pakistan is for the plastic parts only. The gaskets are imported from Germany. So even for the 600 million that are being made in Pakistan, the gasket is not made in Pakistan. The gasket comes from Belgium, Germany, other suppliers, and are just put together in the machine. And similarly, needles are not being produced in Pakistan. Even Amson, which is the largest manufacturer, imports the needle. Because you have to have gauges, right? You have to have a thinner gauge and a thicker gauge, and you have to have a reliability that each gauge will deliver a certain amount of fluid per second through it. So the needle manufacturing is not done in Pakistan. It is just imported, and the gasket is not manufactured in Pakistan, it's imported. And just the plastic, and plastic is done through injection molding. So you basically have these plastic pellets of propylene, and you melt those pellets, you push it into this metal mold, and that forms the shape of the barrel and plunger and cap, and then you pull the mold apart and you drop that plastic piece back down, and that's the injection molding. Now that propylene that is used for creating these mold, the raw plastic, is also imported. Pakistan does not manufacture propylene. Propylene is actually imported from outside, and you have low-grade propylene and high-grade propylene, and you have medical grade propylene, and that decides what will be the quality of the plastic inside. How much fluid will stick, what will be the clarity of the syringe, would there be any stress points where the barrel will break or the plunger will break, and so on and so forth. And then the only one thing is imprinting. You print this structure on the plastic barrel once the barrels are made. So those machines that automate this process, that's the injection molding, the printing of the barrel, putting the gasket onto the plunger, and then packaging it and sterilization. Those machines are available in Pakistan, but again, they're imported. They're not made in Pakistan. So if you want to put a factory up and start doing this, you have to go to Belgium to buy those machines, or you have to go to China, and then there's the quality of those machines, how reliable of a plastic mold they can make, and so on and so forth. So Let's come down to the cost, because I always think that humans by nature are trying to optimize for the maximum efficiency. And although for us optimization is low risk of infection, but for a human an optimization may be money left for the food for their children for that afternoon. And they may have to look at the expense of, what expense are they doing when they're going from one syringe to the other syringe, and how much money can they afford. And so let's talk about cost. The syringe, low quality, high quality. So the highest quality syringes will be BD, for example. BD is kind of a standard for syringes, and a wholesale syringe from BD cost about 25 rupees for one syringe. And we're talking about 5 ml syringe, which is the cheapest because they are made the most. Now, the syringes which are 2 ml or 1 ml become more expensive because they are made less, they have less use. But a 5 ml syringe with a standard 20 gauge or 22 gauge needle, it's about 25 rupees on wholesale, or used to be, because these are imported. So as the dollar goes up, the price will go up. I just quickly searched, there are some online pharmacies, retail pharmacies now. So I looked up on dawai.com and they're selling it for 22.5 rupees if you buy a box of 100. So you'll get 22. Now, if a physician is going to charge $40 rupees for giving an injection, and out of those 40 rupees, if 25 rupees is the cost of the syringe and needle, and what will be the cost of the drug that goes into that 40 rupee injection? What will be the cost of that physician's time and expertise in giving that injection to the patient? So of course he cannot, buy a 25 rupee needle or a 25 rupee syringe to give a 40 rupee injection. So what are the costs for local manufactured ones? So local manufactured, again, are low quality, high quality, depend on their plastic and machines they have. But on average, the cost is about 4.6 rupees for a 3 ml syringe and 4.7 rupees for a 5 ml syringe, but the range anywhere from 3 to 7 rupees. And these are the ones which are standard, reusable, needle change, non-safety needles. Now, if you go to what we call a safety syringe, a safety needle, where you can just, either push a plastic cover onto the needle or, do some safety reason, the cost jumps up to from 5 rupees on average to about 7.5 rupees or 8 rupees on average, even the ones who are made locally, manufactured locally. And there is a small supply of that from local manufacturing, I think 10 to 20 million.
Sorry for interrupting, 2 minutes, okay. And then we'll have to move on. And Dr. Zaidi, I saw your hand, so we'll give you the floor in a couple of minutes. Thank you.
And then if you're importing these syringes, and if you're going for other safety syringes, so if you're doing the non-reusable syringes where the gasket just get trapped once you do the full plunger, then the expense will become even higher. And the gasket will basically seal the syringe, so it's not reusable. But for something like that to work, you have to, the humans can always trick and go around these kind of a problem. So if I show you one of the safety mechanism of a non-reusable syringe, you push the plunger in, this gasket goes into this kind of a locking mechanism. And when you push all the way in, the gasket gets locked. And when you pull the plunger back, only plunger comes out, the gasket remains over there. But it's very easy to cheat it and only use the syringe halfway through. Don't push it all the way in, right? And then the gasket will not lock, will never lock, because the gasket depends on someone pushing the needle all the way in. So I'm just giving you one example of saying that the humans will innovate their way around any cost-effective challenges or problems. And that is the nature of human. I can stop here. But my last comment, sorry, quickly will be that since March 2022, the government ban has gone into effect, where you cannot import any non-safety syringes in Pakistan anymore. That means, and the dollar has gone up. That means the average price of the syringe coming into Pakistan has gone up, probably doubled or tripled, which means that now there is even more incentive to reuse the homemade reusable needles. So the industry will flourish in Pakistan over the next year or two. With the inflation and with the cost of all the imported syringes going up, and there will be opposite effect of what we were trying to achieve. Thank you.
Thank you, Danish. Quick comment from Dr. Zaidi and then Dr. Gilani, and then we'll move on to the next speaker.
No, I just wanted to thank Dr. Bhatti. I mean, this is like unintended consequences. I don't know how to, I don't know how we're going to address that. I don't think there's any way to disincentivize physicians from giving infusions and syringes, and if there was a way of doing that, that would be it. But it's, it's wishes, not like, actions. I don't know how to disincentivize them. But most of the injections they're giving, apart from the vaccines, are not needed. Not most, almost 100%. So I don't know how to give the vaccines and not give anything else.
Many thanks, Dr. Danish Bhatti. It was very informative for us. So now I have a very small question from all of our audiences, and this is our favorite question, and we would love to get the answers, and at least you start thinking about this. What do you think, how many days HIV virus can survive in a tube at a room temperature? So you can start writing your answers in the chat box. And all of those who are present in our very first webinar, we asked the same question. So just think about that, how many days HIV virus can survive in a syringe or tube at a room temperature. Thank you.
Thank you, everyone. So our next speaker is Dr. Salim Salahuddin. Dr. Salahuddin is the professor and head Department of Medicine and Division of Infectious Diseases at the Indus Hospital and Healthcare Network in Karachi. Dr. Salahuddin is a supervisor for ID Fellowship at the Indus Hospital and at the lead TB clinic. Dr. Salahuddin has 40 publications in peer-reviewed medical journals and is the co-author of If Stones Could Speak, Echoes from the Past. So Dr. Salahuddin, the questions that we have for you, I'll just read out all three of them just in interest of time, but please take your time in terms of answering one of them one by one. The first question is, how can the private sector change the lives of the poor and marginalized, including obviously those that are living with HIV? The second question is, how can we replicate the models of excellence witnessed in the private sectors in certain parts of the country and replicate them in the government sector? And then lastly, using our pandemic response for COVID-19 in the country, do you think we can actually replicate some of those models for HIV epidemic using the existing infrastructure and the existing framework? Over to you.
Thank you, Dr. Hamad, for inviting me to this webinar. These three questions are very loaded, and I don't have a single answer for that. But let me go back to the seminal problem with, in relation to what we're talking about, reuse of injections in HIV, hepatitis, and so on and on. HIV and hepatitis A through E, tuberculosis, these are the bread and butter of the Indus Hospital, which provides care to all patients free of cost. And so we see this day in and day out, and this is really there all the time. But the problem is more seminal. It is all related to increasing poverty, increasing illiteracy, increasing population density, all IDs, whether they are all diseases, whether they are non-communicable or communicable diseases, are really more social problems than the real disease itself. Of course, one knows about the pathology and the pathogenesis and the microbiology, et cetera, but these are all very closely socially linked diseases. There is no clear answer right now. As the previous speaker was just telling us about the make of syringes, I mean, this is alarming. This is absolutely terrifying now that we're going to get worse instead of getting better. And the reasons, of course, there are, as I stated, the state of poverty, state of bad governance, more diseases, poorer, worse medical care, healthcare workers who exploit medicine over here. And as diseases increase, whether they are communicable or non-communicable, ill health is there all around. And in order to cope with ill health, the poorer population goes to any doctor who will not charge a hefty fee, in government or in non-government hospitals and private clinics. So they'll go to anyone around the corner. And I've seen this kind of practice even in rural areas, the reuse of syringes, and without any diagnosis, just shoot a needle into the arm, whether it contains whatever bug it may contain. even your blood banks, which are unregulated, convey all these diseases all in one go sometimes. And Arshad Altaf has shown us the outbreaks in every one of the cities, the 4 or 5 or 6 outbreaks. And this is just common knowledge now, and they are all seeping into society. The same people transmitting the diseases to their spouses, to the unborn child. I see women, more women now with HIV than I ever did before, being given to them by during gynecological surgery, obstetric use, of course, needle injections there all the time. So when people are in ill health, they go and demand more and more injections. And the exploiter gives it to them for a price and the disease itself. So I'm sorry, I'm going to be very blunt on this, that I don't see a clear solution, because poverty is rising in Pakistan. Our population is growing at the highest rate in the entire country. So everything else follows after that. All right, the question you asked me about how the private sector can help out, I'm assuming you're talking about IDs. You said, especially in relation to PLWHAs. As I said earlier, the PLWHAs are going to increase because there's more unemployment, there's more drug injection users. So this is not going to be stemmed at any point that I can foresee. It's just going to go on indefinitely and in increments. What can the private sector do? I'm sorry, but private sector is very limited only to good teaching hospitals such as the AKUH, SIUT, Indus Hospital. All these are teaching hospitals, at least what I know of in Karachi. I don't know what is happening in the rest of the country, but I don't hear very good information from them. Government hospitals, in the private teaching hospitals, the selection of physicians is on merit. They're screened thoroughly with their information, their biodatas and so on. And we work very hard to teach our juniors, our colleagues, we have good, very robust teaching sessions. In the government hospitals, selection is made on political basis, on racial basis, on provincial basis, or whatever. Their working hours are from 9 to 2 o'clock, and most physicians don't even show up from till 10 to 12, and then go away in their private practices. So how are we going to translate good medical care to government hospitals? I don't see any way out. We have a very low budget for healthcare, and most of it goes into salaries of professors and in the faculty and in the teaching cadre. It's not going to increase. The Minister of Health is not even a physician. He's had some other kind of a profession, and now he's telling us what to do. He's paying more attention now to theoretical possibilities right now about monkeypox prevention. Please, we've got more problems over here ahead of us than any other country in the world really right now that I'm thinking of. So our problems are not going to sort out easily, and it's just horrifying to think that we're going to be using more needles, more unsafe needles. What was the third question Dr. Hamad asked me? I can't, can you just repeat that for me, please? Maybe I have it somewhere here. Dr. Hamad, you asked me the third question. What was that?
I think that you've already included the answer to that in your previous.
Okay, I'm sorry, I'm not very
thank you.
optimistic, but as I work at the Indus Hospital for the poorest of the poor, and patients come to us not only from within Karachi, but from all over, all provinces, even from as far away as Waziristan. I have patients who are with HIV, with hepatitis C, whatever. They come to us from far distant places because there is no good medical care anywhere in between. They're more happy with Indus because it's a free care and good medical care. Of course, the other institutions are excellent also, but they are also commercial institutions, so they can't go over there. And we are overcrowded, overburdened, and really stretch ourselves beyond limit. I don't see a very happy solution. I'm sorry, I may sound very pessimistic, but this is reality. Thank you.
Thank you. And Sama, handing it back over to you. I have to sign off now, but back to you. Thank you.
Thank you very much, Hamad. Thank you so much, Dr. Salahuddin, for that excellent talk and your comments. And thank you for all you are doing for these patients. So our last speaker today is Dr. Bushra Jamil, who's been with us from day one. And she is known to all as the president of the Medical Microbiology and Infectious Disease Society of Pakistan. And she's an infectious disease consultant at Aga Khan University, and she has been teaching us from day one about the frontline challenges in Pakistan. So Bushra, please, first of all, one question I had was this reused syringes and the auto-destruct syringes. I think in 2017, they had brought up the issue in Punjab of reused syringes, and I don't know how long it lasted. And then the auto-destruct syringes. So that is one thing, and then all your comments about how can we solve these issues. Thank you.
So the first time this issue was brought up of auto-disabled syringes was in 2011, when the Sindh Provincial Assembly passed a bill in 2011 prohibiting use of reusable syringes. So that was a bill which was passed in 2011. But could not be enforced. So the problem of syringe-based HIV transmission was recognized even then. And the urgency was such that this bill was passed. But there is a serious disconnect between policymakers and whatever is the ground reality, because auto-disabled syringes were not even available in the country. So how can you enforce usage of something which is not available freely? So that was one thing. But then the federal government in 2021 passed a legislation banning use of reuse of the conventional disposable syringes. And again, this problem of availability came in, and the problem of cost. So what they did was they removed the import duty on auto-disabled syringes to reduce the cost so that they were more widely acceptable. But there are problems with these auto-disabled syringes. There is one very interesting point which came up, which I'm going to tell you, is that only 5 cc syringes are available, which are auto-disabled syringes. And the practitioners in Larkana have, even before adopting the usage of these syringes, have come up with a strategy of using these syringes on multiple patients. So they can fill up a full syringe and inject 4 people with 1 ml each before discarding the syringe. So that's the ground reality, because they do not understand the problem, and cost is a big player here. So they are trying to cut their costs without actually understanding the kind of harm they are posing to the population. So this was one interesting point. So if you want to ask more questions, please do. Otherwise, I have a few more points which I would like to take up. Should I go on?
Sure, go ahead, Bushra.
So regarding funding, so having served as the national coordinator for the HIV, malaria, TB programs in Islamabad, I know that there is no dearth or lack of funds. There are a lot of funds available, but the entire fund is donated by Global Fund. There is no national or provincial funding. So it may be there on paper, but the government has not allocated any funds for control of these 3 major diseases, HIV being one of them. But even then, there are ample funds available. What is important is a lack of dedicated leadership. So you do not have a good leader running the HIV program. So again, we had a radiologist who was heading the program, followed by 2 dentists. There was a dentist in between for a few months, and the current Deputy National Coordinator is again a dentist. So that will remain an issue. So your decision makers have no insight of the problem at hand. So how are they going to ensure that funds are allocated and used appropriately? And I can tell you that the warehouse at the Common Management Unit is fully stocked. In fact, there is no space to store any more condoms, lubricants, and other such things which are part of the preventive strategy. So everything is there. It's not sent out to the centers. It is not being used. It is just being wasted. So it's the capacity to use the funds appropriately, design strategies. That is where we are lacking. So even if that is addressed, our program will start doing better. Then comes the issue of unregistered practitioners. Okay, so the unregistered practitioners, or quacks, we do not call them quacks again. That's a very good point raised by Dr. Zaidi. So they are actually registered with the healthcare commissions. So it's not that they are not being engaged. And if this is, they're engaged appropriately, they may actually be taught or made to realize what harm they are doing by not following the principles, principles of safety. So perhaps greater engagement of a society like ours with Healthcare Commission is one of the ways forward. So we have had a good engagement with Sindh Healthcare Commission, and we have actually conducted online sessions because it was COVID last year for Hakims and these practitioners. So perhaps some increase in activity focusing these practitioners is one of the way forward, and maybe we should work on it and conduct actual hands-on sessions for them in safe, at least safe injection practices. And lastly, physicians and clinicians are not aware of the kind of risk they are posing by just cutting the costs or trying to save a small amount of money. So this is a preventable harm. So this kind of principle we use in curtailing healthcare associated infections. This principle has probably not been used in the community, but this is something which may be tried in the community, where people are made to realize that through modification of simple practices, they can actually do a lot of good and prevent harm. So again, behavior change, focusing on making people realize that this is a preventable harm, and being cognizant of the fact that auto-disabled syringes are not applicable in all situations, especially in IV drug users. It is impossible to use an auto-disabled syringe. So if you ban the conventional disposable syringes, actually we will be in a mess. So this, the policymakers have to realize, but again, there is a disconnect.
Okay,
so I think I've answered.
Thank you so much, Bushra, for good ideas and pointing out the ground realities. And Jazakallah to all your efforts, despite how grim the situation seems. But we can just do what we can. But appreciate all the comments. Thank you so much. Fiza, do we have any questions we can take?
Yes, I'll take this question first, then we'll give time to Dr. Najam Zaidi for his question. So someone is asking any comment about consultation skills of doctors who have role to satisfy patients about reuse of needles or injectable drugs. And the same, actually, participants asked the question that any law for those healthcare workers who reuse syringes in case of violation, any penalties. So who would like to answer this? Bushra or Naseem are in more suggestion to answer this question from Pakistan. Bushra, I'll go for you actually.
I can only say that punitive measures don't work. So if you don't have any strategy to implement your policies, how can you implement punitive measures? It's as simple as that. So first of all, the availability should be there. Then education of both public and healthcare workers. And then comes legislation with its implementation, and then accountability, which may not necessarily be punitive. It may just be that you need to reinforce and retrain people, not punish them.
Yes.
Dr. Zadi wanted to comment.
I completely agree with the punitive measures not working. I think the only punitive measures in Pakistan that will work is Allah watching you, and it does work because foundations like ED and everything have been successful in Pakistan with just that. The charity work that is done in Pakistan is unbelievable. If there was any funding shortage, that would come through. My two things that I wanted to question Dr. Abbas and Dr. Jamil was, in the US, where we have more resources, there is the distribution of drug as prevention. If you reduce the viral load in individual patients, then there is no transmission. Is there any role in that? The other thing is, I am an HIV provider. I give drugs to patients, HIV drugs, and I don't test anymore for resistance or even side effects of drugs, as long as the aim is to get the drug into the patient. And if they have side effects, they'll tell you. So I feel that the testing and viral loads and everything else, it's great, but I don't think that given tremendous use of the newer antiretroviral drugs, I believe that we should more focus on just distribution and large amounts of the drug to all of the sufferers. But I don't know how to go about doing that in Pakistan. And then finally, I was looking at Dr. Bhatti's point with regards to needle reuse and yours. In the US, even without the non and self-destructing needles and everything, needle distribution programs to IV drug users, whatever kind of needle you give them, if you were to flood the market there and ensure a way that those needles are not reused elsewhere, that would be a way to prevent this from happening within those communities. But I don't know how to, again, go about doing that anymore. I used to.
I think I'll let you answer that, Bushra.
Yeah, so there is no lack of ARVs here. The supply is ample and it comes free of cost because the Global Fund is providing it. It's just a matter of having ARV centers functioning appropriately. So because you've had poor leadership, the centers are fewer in number. And even though the physical facilities are available, there is a lot of reluctance on part of NACP to actually open up centers. That's one thing. But the drug supply is there, and both PEP and PrEP are promoted by the Global Fund. So the supplies are ample. And if we ask for more, the Global Fund is going to give more. So that's not an issue at all. It's just the strategizing and disbursement and monitoring. That is totally lacking. Regarding the second question, what was your second point?
My second point was distribution of whatever kind of syringes to IV drug users.
Okay. So Nayi Zindagi is the biggest NGO which deals with IV drug users, and they are actually principal recipients of Global Fund. So I've actually been to their centers, seen their patients, how they work. So I think they're doing a fairly good job because they have a needle exchange program. So they give fresh syringes and needles to their clients and collect the used ones. So I think they are able to recover up to 60% of used needles, which is good enough. And they have registered all the drug users and identified hotspots in all major cities and towns of the country. So I think we should invite them in one of these webinars and let them present what they are doing. Their coverage is fairly wide.
May I talk about my experience here at the Indus Hospital? In the ID clinic, we have a very large cohort of HIV patients whom we treat systematically with proper follow-up, viral loads, CD4. But it is required by the NACP that we every 6 months test all patients for viral load and CD4. It's a bit expensive, yes, not always needed, especially for CD4, because we don't change our decisions, but it is a requirement, and we are upbraided, we are scolded, if we do not perform these tests periodically according to their requirements. But be that as it may, we also have a separate section for people who inject drugs, MSMs. It's a proper program, and all these patients are brought to us through Nayi Zindagi and other NGOs. These are the most difficult patients to take care of. They're lying under bridges, on sidewalks. They continue to inject drugs or share drugs, even though they are still receiving ARV from us. They're homeless, or they land in jails. Their mothers complain to us कि बेटा हमारा सुनता ही नहीं है, वो वैसे ही नशा लेता रहता है. So they're very, very difficult to manage at all stages. Yes, we do get a good supply, a regular ongoing supply from NACP for the ARTs. No complaints about that. No complaints about getting the kits for testing kits. They're all there in order. And of course, we have a proper system of registration, of collecting data, and then sending it onwards to SACP, Sindh AIDS Control Program, onto NACP. It is all globally funded, and I think we have a very good program. Those who are not PWIDs, those who are not homeless, they carry on with us very well. There are very few defaulters in that, but those who miss on their drugs and land in jail, well, then of course, that's difficult, even though we do have a structured social service to track them down. Our doctors even go out into the jails to counsel, to provide the drugs, to get diagnostic tests. We have to watch out for opportunistic infections. Can't just let them go up in the air. Otherwise, there's no point in treating them. But those who are doing well, who continue to do well over months and years, why then I've had patients who've been on ART for 10 and 15 years and are still doing well. But it's the separate category of people that we have to really watch out for. And they're not only HIV positive, but they're also hepatitis C, hepatitis B, and drug-resistant TB. So we have really challenging patients amongst us. And then they land up with opportunistic infections, cryptococcal meningitis, MAC, and so on and on. So we have a very robust program. It is very challenging, and our fellowship trainees are learning a lot. It's really an unusual way of saying it, but I think they're gaining a lot from this kind of a cohort of difficult patients. Thank you.
I have a comment here regarding viral load. So viral load is one of the key performance indicators for the program, because it tells you adherence, which is very poor in Pakistan because of many reasons. But the viral load testing and even CD4 is free of cost because it is funded by the Global Fund. So large majority of tests are done at AKU because NACP has a contract with the Aga Khan University, but there are other centers which are also doing viral loads, but it doesn't cost anything to the patient. It is part of the fund.
Good to know. I have one point that I would like to ask Danish, because you gave us such an interesting perspective about UNICEF buying all our manufactured syringes. How can we, is there any room there to, can we stop that, or can we have our own manufacturing stay in the country? What do you think is the solution to that?
So I think, UNICEF is not doing out of malice or anything like that. UNICEF actually gives us access to a lot of other purchases from other countries that way. So we could get access to some cheap discounted purchasing prices for some of the other items we need through UNICEF. So it's kind of like a marketplace for bulk purchases, and then different countries can get in and get some of those supplies. So it's not necessarily bad. I think overall, the need is to find a way to incentivize needle and syringe manufacturing in Pakistan. We should be exporting it because there's a global shortage. India last year, for example, doubled its manufacturing capacity. So just one supplier had a capacity of 550 million syringe production, and they doubled it to 1.1 billion syringe capacity manufacturing last year. So there is a global shortage of needles and syringes because of the increasing utilization and better access to healthcare and different programs trying to support better access to healthcare. So we could actually be exporter of needles and syringes if we invest into it and find a way to do it. And with more and more bans coming, for example, for these non-reusable or single syringes, there is an opportunity because those items will be in shortage that we could start manufacturing in Pakistan and export it and get a good revenue. So actually, UNICEF purchasing it is a good thing because it's a guaranteed sale. And so any business where you're investing and you know that there is a buyer who will buy anything that you can manufacture for the next 3 years or 5 years, that's an amazing opportunity to go into that market. So we want UNICEF to buy everything that we can make. We just need to make it.
But it's not good for our own shortage. I mean, we are saying that it's going from 25 rupees to 40 rupees to maybe triple the amount. I mean, don't you think it's sad that we don't have enough syringes for our own place and we are this great business opportunity for UNICEF? I mean, looking at it from that perspective.
Yeah, that's true. But I'm sure, UNICEF is gonna help us get more cheaper syringes if we can. But of course, in a UNICEF, there will be leverage from all countries, and every country is trying to. If there's one syringe and 3 buyers, then of course everybody has their own leverage, and so on and so forth. That's the market dynamics. I think long-term solution is to find ways to increase capacity manufacturing in Pakistan, and we created a ban without creating an incentive around it. That was kind of a disconnect. Although I think there was a plan by government that they offered that they will guarantee by 50% manufacturing capacity of any new manufacturing plant. I think in 2020, Minister Zafar Mirza at that time made that claim that the government is interested, that they will give you a guaranteed offer to buy 50% of your manufacturing capacity if you put in any manufacturing in Pakistan. But nobody took them on their offer, for 2 reasons. Governments change and you don't know if the claim will disappear. And number 2, that the Pakistan government typically is the lowest cost buyer. So Pakistan government, when they're putting a bid out to buy syringes and needles, if the average selling price is 4.4 rupees or 4.5 rupees, they only allow you to sell it to 2 rupees to them. So it's almost at cost or below cost kind of a purchase. So that's why there was not enough of an incentive for someone to come in and say, okay, I'm going to set up a plant to do manufacturing. It's about $2 to $5 million of an investment to set up a plant to start manufacturing 150 million syringes or needles. So it's doable. It's not a huge money. There was an announcement yesterday that Sequoia Capital invested in a new digital bank in Pakistan, and their seed investment is 17.5 million. So for a 17.5 million, you can make a full plant that can make about half a billion syringes or needles. But in digital bank, they know they can make money. In syringes and needles, they're not sure.
Got it. Well, I hope, inshallah, somebody will start manufacturing, and that's an interesting perspective. Well,
I have one last question from Dr.
Okay.
Danish Patti.
Mm-hmm.
So, Danish, from last 2 years, you have been as a merit chair. You have been dealing with so many different groups, internal medicine, family medicine, and all of different courses and groups. So what do you think, how we can start these talks, needle reuse issues in other groups' platforms? Because needle reuse is not only affecting HIV, it is Hep C and all of others. So any idea how the other groups can start these talks?
So, I'm not so sure about other groups, but let me say this way. If you're trying to get to people in Pakistan or healthcare diaspora in Pakistan, there are 2 routes to get to it. One is alumni collaboration. So we in MERIT, we have representation from all alumni, and many alumni presidents are actually part of MERIT committee. And we can reach out to them, and ask them that, can you ask to have programs within your university, and they have a big access and quite a big of a following. And then the other process or have been to partner with the specialty associations. So neurology association or cardiology and dermatology, rheumatology. And there is opportunity to connect through that too. And many I know, and many we can find within APPNA, people who know, for example, cardiology is a very big association in Pakistan, very well organized. They do a lot of programs, and it's easy to ask them to give us a spot or a slot to talk about this and project this issue in their annual meeting. And so, for example, another big platform, although it becomes a little more politicized, is the Pakistan Islamic Medical Association. In their annual meeting, I think they have like 20,000 or more GPs attend. Similarly, there is family practice associations. Their annual meetings are attended by 20,000 plus people. And if we can get a spot with them, that will be a very easy way to access to a very large cohort of physicians in Pakistan. And I have many of those connections.
Thank you very much. And now, actually, for our last comment, in our
somebody has raised their hand, Rabia Zia.
Yes, that's what I am telling. Okay. She wrote in comment chat, so I told Walid to include her. So Rabia Zia, please go ahead.
Hi, I'm Rabia. I'm an overseas Pakistani. I'm from England, but I'm working in Pakistan. So I am working with, and we are setting up a manufacturing plant after doing all the analysis as per AMSONs and all the stuff that was mentioned just now. We're setting up an auto-disable and safety needle plant in a special economic zone in Punjab. And the needles and the syringes are going to be FDA approved quality, although we have to do lots of tests to get FDA approval. But the prerequisites and the polypropylene and the blister packing and the marking and the colors, everything is as per FDA requirements. Because the investors, there are two doctors who are from the US. One is a white American, and he's investing in Pakistan. It's amazing. And he's a majority shareholder. And he's come up with, well, he wanted to set up a stent and catheter set up in Pakistan because, moved from China to Pakistan. But they have started off with the syringes. Now, it was very interesting to hear about UNICEF and what AMSONs is doing, but just let me be, because I've done a lot of market research, because obviously we had to do the feasibility because we've had local funding from the bank as well. It's a $4.5 to $5 million project because you're spending about $1.5 to $2 million on plant and machinery. Then you've got working capital of $500,000 for your raw material that has to be imported because Pakistan does not make or have medical grade, raw material. It has food grade, but it's not medical. And then obviously you've got the infrastructure, the land, the building, everything. So it's not a cheap investment, but obviously it hopefully, commercially to pay off. But more importantly, if there is a biological war in the future, then at least Pakistan, who's reliant on 95% of imports of all of these medical devices, other than stainless steel, it's a very, very dangerous scenario for Pakistan itself. So we are setting this up. We're in the phase of the machines being ordered, the plant and machinery will be delivered by October, and the plant site is being set up. It's being built now. So I'd like to be engaged, with all of you. I'm not a medical doctor. I'm a JP Morgan. I'm an investment banker. But my father was a doctor in England, so I have a lot of insight into medical terms and terminology. So I'd like to be engaged in order to understand, one, what is it you guys need from an HIV preventive factor? Because one of the SROs that somebody mentioned was, yes, it came out last year. I was working with Dr. Faisal Sultan, who is the CEO for shortcomings, and he was made the health minister. And I work very closely with him because I wanted to figure out what's DRAP doing and what are they doing in order to incentivize investors to come to Pakistan and set up factories and investments in electromedical devices. But anyhow, DRAP is a nightmare. It's a mafia. So that's not been, there's been no reforms on that side. So we have to deal with it as we have to deal with everything else. But other than that, there is a lot of incentive in the special economic zones that the governments, no matter which government comes, because it's a CPEC association with China, so we get a lot of incentives. And if anybody is looking to invest in Pakistan, now that we've gone through the whole thing, I've been involved in it for the last 2.5 years, understanding every step of it. So, we can always help them. We can always understand people who really want to come to Pakistan and do something, especially in the medical field.
That is amazing, Rabia. By the way, how did you hear about us?
Dr. Uzair from Canada, he called me yesterday. Well, he was in touch with me for a week because I am also sort of political. I created PTI in the UK in 2004, and I was very close to the whole setup. So when PTI came into power, I was quite in tuned into, as an overseas Pakistani, what are the things that we can do here? So Dr. Faisal Sultan put me in touch with DRAP, and DRAP put me in touch with Dr. Uzair. And that's how he linked up with me about a couple of weeks ago. And then he and I spoke yesterday for the first time. And he's the one who invited me to this seminar because he knew what I was doing. And I'm the CEO for this manufacturing unit. And it's called Monitor Health. It's Monitor Health USA subsidiary, Monitor Health Pakistan.
Okay. Well, that's
many thanks,
amazing.
Rabia. Actually, thanks for joining. And now we'll keep in touch. But please make a note that as I said in introduction of this webinar, we do not affiliate ourselves with any political party in Pakistan.
Yes, I understand. So I've had to take an apolitical role after I started this industry. So I'm now not engaged with the government at all since 2018.
And for your information, Dr. Faisal Sultan, actually, he was supposed to join us today, but he was busy somewhere else. And he promised that he will join for a few minutes if he can. But I think he didn't get time.
No,
so any other questions,
I was
comments?
spoken this morning.
Yeah. Sure. Go ahead, Rabia. So any other comments, any flow, or we can just say goodbye to her. Bushra, you mentioned one question actually. I want to know which question is that from Dr. in the Q&A section.
I want to quickly just respond.
I've answered all of them. Yeah.
Okay, sure. Thank you. Thank you.
So I will just quickly respond to Rabia. So thank you for joining. Dr. Uzair is a good friend, and I heard your name from him. I reached out to him as I was doing research for this topic, and I would love to connect and partner. I don't know if he mentioned about Tasdeed, but it would be great to collaborate.
See the imminent benefit of these webinars. Yeah. We make good connections with everyone.
Yeah, sorry, I just have a last point. Can I just add something? There is an organization in Punjab which is called PDN. It's called Punjab Development Network. It has 195 NGOs listed with it all across Pakistan. So all the NGOs that you mentioned today are also part of that. And you must have heard about Akhuwat and Islamic Aid and Muslim Aid, all the British ones, as well as some from the US origin, some locally from Pakistan. They're all part of this PDN. And I'm also part of that PDN, which is basically, a network. So if there's anything that you guys need in that sense, then I can also be helpful to you guys.
Political savvy is needed in this situation, whatever the party affiliation. So we do appreciate anybody who has the tools to make about an effective change, however they acquired them, right? So there's no winners or losers here, but I really appreciate that. I volunteer my expertise, however little it is. If anybody needs an infectious disease doctor, and I think there's a couple more in this forum here, I would be more than happy to help.
Well, thank you, Dr. Zaidi. We are looking for anyone who cares about HIV, who can, take it forward. And thank you, Rabia. That was a very pleasant and mashallah, jazakallah on your efforts. Now, we just thought about it that somebody, inshallah, will make a plant, and there you are. So thank you for that. And looking forward to overcoming this very interesting financial aspect and, delivery of syringes. And I think you will have a lot of power in that. I think, what do you think, Bushra? A lot of things can be accomplished if there are people who are actually invested in this in Pakistan.
It will be actually great to work with Dr. Rabia because we have not been able to actually engage with Punjab. They keep to themselves, they don't share the data. It has been impossible to engage the healthcare, Punjab Healthcare Commission, because once you are engaged with the healthcare commissions, it's easy to reach out to GPs and even the other practitioners. So that is good. And the other, this possibility of engaging NGOs. So that is important for actually patient engagement as well, patient education and engagement. Empower them to make their own decisions.
Absolutely. I didn't know that this provincial DN that she mentioned, is that in Sindh also, Bushra, or just in Punjab?
Haven't heard of it.
The PDN that she mentioned.
You mean it's only in Punjab?
Okay.
But it has NGOs that are working in Sindh, in Balochistan, in KPK, and in Gilgit-Baltistan. They're all there.
Okay, everyone, we are way over limit our time. So many thanks, everyone. Dr. Najam Zaidi, Bushra Jamil, Dr. Sadal Taf, Dr. Naseem Salahuddin, Rabia Zia, and especially Saima Hamad, everyone. And Waleed, especially, you can see these two APPNA-MERIT logos. This is our big support from Pakistan.
Yes,
thank you very much.
Yeah, thank you. Assalamu alaikum all.
Khuda Hafiz.
Khuda Hafiz. Thank you, Bushra.
We always overrun time.
Yeah, but that was interesting. It